right, so the project, the topic is basically, in a nutshell, about the elderly in this area and their nutritional status, whether or not they're getting enough food. We haven't really quite narrowed down our aggregate, I don't think yet. I mean, we wrote the description, but I don't think we're there yet. We still need to do more thinking based off what we learned in the interview. But basically, I just want to start off with if you have any general thoughts on that topic, what you think. Are there people in this area that you think are not getting enough food, I guess?
Sure, absolutely. I mean, you have a number of things that contribute to that. One is very rural areas will rely, if they can't get their own meals, they might rely on Meals on Wheels, but they're frozen, so they might not always like them.
Mm-hmm.
They don't always have functional capacity to make meals, so they rely on foods, frozen foods, or really quick prepared meals, which are not ideal. You know, we talk about canned goods and meats and things that are high salt and sodium. If a spouse passes and the spouse was the primary meal preparer, that can play a key role. Of course, there's a lot of outward migration of their family, so they don't have as much support. So when they're not feeling well, they don't always feel like making a meal.
Right.
So they tend to get things that are just, not as. We had a case this week. Got a call that supposedly the fellow hadn't eaten since Saturday because he had no money.
Okay.
Diabetic.
Mm-hmm.
I mean, there was a lot of things contributing to that case. There was some confusion, lived alone. So, based on the environment, we anticipate he probably didn't eat very well, but, we had some, but not a lot of options. So, I mean, there's a lot of issues there. Some just don't like Meals on Wheels. Some don't want to change their diet.
Yeah.
Okay. So it's kind of interesting you say that, because when I talked to Tyler,
Dalker?
yeah, I don't know if it was the region, because he serves a narrower region being in the Fort Kent, but he said that he basically doesn't even run into that issue in terms of people coming across his desk that are just like basically going hungry. So you think there is any difference in like sort of that in-between caribou?
I don't know if I'd say they're going hungry. I would say when I think of nutritional, I think of are they getting the best nutritional plan or meal for their diet, for their comorbidities and whatnot.
Mm-hmm.
I don't know that I'd say people are going hungry in Rustic County.
No.
I just think it's the food choices are limited more so, or the food options, and therefore they have a narrower opportunity in terms of that. So, and I don't know. He's primary care. I don't know what his population panel is if he sees a lot of older adults. And unfortunately, I'm going to tell you honestly, I'm going to pick on primary care, but I'm sure you'd agree, they don't really screen very well for that.
Mm-hmm.
No.
Because I don't know that they really truly do or don't know.
Yeah.
Because they don't ask per
Right.
se, or they don't think much about it.
Well, the other thing too was that I kind of had the thought after, just sort of generally thinking about it, but he said it is quite easy for people to get people signed up on home health. It's not really a barrier for him, so he is probably seeing a lot of people. Obviously.
Can you tell about the wait list in
Yeah,
Maine?
really. We're looking at a 6-month wait list right now for people that don't have main care.
Mm-hmm.
There's a
so
significant
amount.
gap. And then you also have certain rural areas that cannot be staffed. So coupled with the fact that they might be on a wait list for services, they might also be on a wait list for staffing.
Mm-hmm.
And there's still cases that are not fully staffed. So they have a portion of their hours staffed, but not fully staffed.
Yep.
And I think about people who live in Allagash, where do they go to a grocery store?
Mm-hmm. And that was something I talked about too, and you said, they probably are going to the convenience store and getting the microwavable stuff. But where I was going is I wonder, he's thinking about people who bother to even go to the doctor. I mean, there's probably a population of people who don't even do that, who are definitely not getting home health.
I can tell you right now, there's a generational issue in which patients of that age group don't always tell the whole. When they go to the doctor, everything's fine.
Mm-hmm.
They don't really talk a lot about their issues.
Well, especially up here in the northern area, they have a lot of pride. They might need help, but they're not going to say that they need help. So that's especially up here compared to the southern part of the state.
Yep.
And some people think Meals on Wheels is the answer, but no one looks at the Meals on Wheels and do they really eat it? We have patients that get Meals on Wheels that barely touch it.
Right.
So they think it's the solution. Oh, patient has Meals on Wheels. I don't have to ask about nutritional status because they have meals.
Right.
But nobody asks, are you eating it? Do you like it? Do you warm it up? What do you do with it? I mean, we know a fair proportion of patients that don't eat much of it because they're just, not to say they're not good meals, so I don't want to discredit. The Meals on Wheels program is a fantastic program. But we have clients out there that are very set in their ways about what they want to eat and how they want their food, and they want it salted, and they don't want it bland, and they don't want this, and all that stuff.
So I guess kind of going off that, is that a common goal of your home health nurses traveling to, is that something they're frequently working on, is trying to get them to eat more?
We put Denise in charge of resources per se, but yeah, every assessment that we do encompasses a nutritional assessment. And obviously that's looking at, weight and diet and medications and what are special diets that they need. So we assess it routinely. If we find that they don't have adequate resources, that's when we refer to Denise. Denise is the social worker, goes in and works with patients and families to identify the resources that are available in our region and hopefully align them with some of those so that they can take advantage of them.
I refer a lot to the Farm Share program, where they get fresh vegetables with local farmers. They get a voucher, and a lot of people don't know about that. So when I do mention it, a lot of people access that.
And that would only be seasonal though, right?
Correct, it is
So
seasonal.
So that's something
Yeah,
that would be
it's seasonal.
part of the issues
Right.
we might see in Aroostook County.
Yeah, I didn't know about it. It's the first I've heard of it.
Yep.
But they have to go to the farmer to get the food.
Yes, the family member or friend does go and pick it up for them.
Okay.
So it does require transportation.
Right.
If you don't know anything about Aroostook County and transportation for older adults, it's a significant problem.
Yep.
They can't find transportation. There's no meaningful transportation for them. If they can't drive, depending on the region, you could take the ARTS bus, but depending on where you live, you might be sitting on an ARTS bus all day to go do an errand that takes you 20 minutes. They might not have the functional capacity. Some transportation available through various sources depends on their handicaps and their limitations, because some can't help transfer in and out of cars, and so there's a lot of pieces there, but transportation is a big issue. So I would say to somebody like Tyler was saying, none of my patients, the patients that can't travel, how are we're missing a significant gap of the population in terms of that issue.
Speaking of the family, how, I can't expect you to get a number off the top of your head, but how many would you say don't have family to help them with their?
I don't know if I could guess on that.
It varies, I don't know.
I mean, they all, I think, for the most part, have, there's a fair proportion. I'd probably say 90% have family involvement. It's the level of involvement that's in challenge. So we have very active families, but they live in another state. And so their resource and their ability to assist is by phone. That doesn't necessarily meet all their needs.
Yep.
I mean, we have probably, I don't know. I don't even know if I could guess.
Yeah.
And then you have some of that family here that are not helpful at all.
Right.
So I guess finding out families, and if there's family, it depends on the level of need and the level of assist that they require, I guess. It's a mix.
Yeah, I figured it'd be hard to tell because you wouldn't know off the top of your head, but I just didn't know. I kind of got the impression talking to Tyler in the Fort Kent region that the family is typically a big help. So I don't know if you expand to coming down more here, if that changes, or
if they have family in the area, the general rule from that perspective in terms of the St. John Valley is the families are very supportive. They're very strong families, but we're seeing a larger proportion of folks that are their kids are dying before them.
Yeah.
They're 90, they're 88, their daughter's 72. She's got more health problems than the 88-year-old.
Yep. Happens a lot.
And so, again, it's all relative in terms of what they're able to assist with. And truthfully, if you're looking at nutritional status, they'll make them a meal, but financially we don't see a whole heck of a lot of ability to support.
Right, not financially. But a lot of the families do bring in meals.
Yeah.
Yep.
So why don't you, Denise, tell me a little bit more about the logistics and the barriers to these people getting access to the home health. What's it usually look like for them to get started on that if they get a referral?
Well, typically before, we had one assessing agency for the state of Maine, they used to be called Gould. When we would refer, they had up to 5 days to go to the home to complete the assessment.
Okay.
They've recently been bought out by another company called Change Health Systems, and it's not going as well, I think, as they ever anticipated. So right now, the referral process, I've seen it take up to 30 to 45 days to get an assessment for people that should typically be waiting 5 days for an in-home assessment. So those are the people that have main care. There's no wait list. The people that do not have main care, there's another program called home-based care that is funded by the state of Maine, but that they get dollars every so often. That's where we're looking at a wait list of at least 6 months at this point because of lack of funding.
Okay.
And you think, well, they don't have main care, so they have more financial. It's not. I mean,
No.
they're over by dollars
Right.
and
A
cents.
dollar could be $9.82 a month, and because of that, they don't have main care. So I
But
think
they're living on that.
yeah.
Mm-hmm.
So they don't have other means to get other resources. So they sit on a waiting list.
Do you have any insight on what these people are living like in the meantime, or are you kind of just you
No,
don't
they
know
move.
unless
They
the nurse.
fall, they break hips,
Right,
they
they
go to
end up-
hospitals, they end up prematurely in an institutional setting because they didn't get the help they needed at home. So when they fall and they break their hip, they can never make it back home, and they go to assisted living and boarding homes and nursing homes. Probably prematurely. That's anecdotally. I don't have specific evidence, but I always said I'd love to do a research project on taking those folks sitting on that waiting list and studying them, assessing them for the time frame that they're on the waiting list, and comparing them to their peers that are getting services simultaneously. And what you'll see, I anticipate, is you'll see a significant decline in condition for the people that are not getting services, resulting in higher health care or home health or community-based costs because they end up in institutional settings because that's their only option at that point.
I mean, that's kind of, in essence, what the point of our project is. But the thing is, it's kind of hard to really know.
You'd have to have two groups,
Yeah.
and it's hard to get to them, yeah.
And you don't really know exactly what's going on in the homes of the people who are on the waiting list, because there's not a nurse going to see them by definition, because they're not part of the system yet. So,
Right.
but
No, they sit and wait.
mm-hmm.
The only time they change is, again, if they go a higher level of care and all of a sudden would qualify for main care because they're nursing home level of care.
Right.
That might be what you'd see, but other than that, it means they've deteriorated pretty quickly.
Yeah, unfortunately, I don't know, it's pretty, the 5 day was a good window for when we would refer, but now and there's one assessing agency, so it's not like you can call somewhere else to get an evaluation, so that's unfortunate at this time. So hopefully they're working on the issue.
And the system itself is complex. Denise gave me
Yes.
a story. We saw a patient who came home. She had broken a hip, I think, in Ashland.
Yep.
And came home from the nursing home. And there was a significant disconnect between her going home and the services she could receive.
Yep.
So she was deteriorating because she needed a level of care that nobody was connecting the dots until Denise said, well, wait a minute.
Yeah. Yeah.
But without people to navigate these people, she would have sat and not had any services for.
No. Yeah. Yeah.
Do you have any sort of information, whether it be statistical or just anecdotal, about what the conditions are often like when a nurse first enters the home of someone beginning home health, and if they're able to improve that, especially in terms of the food? Are they going into these homes when they first get referred and kind of seeing empty refrigerators and working to fill them, or do you?
I mean, it's part of the assessment process. I don't know that, we're finding a whole lot in terms of that nutritional, that they have empty Again, I think there's for me, it's not so much that patients are hungry, it's that they're nutritionally impaired because they're not really getting the food that they're eating, but it's not really the best food or the right food for what their needs are, for their nutritional status, for their chronic conditions that they're trying to manage. I think it's, it's not the best food choices. So a lot of the work is more just educating them and looking at resources and connecting them with available resources for those types of sources. So whether it's Meals on Wheels or looking at other options, recommending, nurses often will recommend supplements because they're nutritionally declining, and so they might reach out to the provider and talk about how to use supplements to help them with their maintain their nutritional status, that's what I would say. I don't know.
Yeah. I don't think there's improvement, because most of them are chronically ill. I mean, there's probably we get a better insight as to, because the workers can go to the grocery store
Yeah.
for them. So
Yeah,
that's
the work, staff can cook.
right, and staff can cook
Yep.
the meals, so.
Yep, so that helps them a
Yeah.
lot.
Yeah, that's kind of what I was going to go with next, is like how much your service like directly works on that. I mean, so they
It does, yeah.
Yep.
they do occasionally go shopping for them.
Oh,
As
often,
needed,
most of
very
them.
often.
The majority of our patients take advantage of sending our staff at least once a week to the store to get groceries and other items. And staff routinely are engaged in some type of meal. If they're not cooking it, they're helping serve it. If they're not serving it, they're overseeing or supervising to make sure that the patient eats. And it's not uncommon. We actually, often when families from away are getting early services for their loved ones here, that's often a common request. Can you go during a mealtime? Because I'm concerned mom and dad aren't really eating like they should. So can you make sure your staff is there during meals so that you can make sure they eat? So we do get that. I find that
Yeah.
one often.
And you mentioned the farmers vouchers.
Mm-hmm.
Do you directly work with Meals on Wheels to get deliveries to home, or is that something they kind of do?
I
On their
initially
own.
make the contact and the referral.
Okay.
So the thing with Meals on Wheels is that they're under 65. They don't want to serve that population, even though you might have a person in a wheelchair. I had one, he's shaking, he had a brain injury, he's in a wheelchair, younger guy. You know, and when I called initially to make the referral, they refused it because of his age. I knew the person personally, called, pulled a few strings, and lo and behold, I've got a Meals on Wheels. So, you know, Meals on Wheels is good, but typically they'll only serve 65 and above.
Okay. And are there any other programs that you work with besides those two?
For meals, mostly it's the farm share that I refer, the Meals on Wheels. Those are the basic two that
If people are in food, we recommend food pantries.
Yeah, there's food pantries. There's an organization called Hope, who deals with people that are struggling financially with food and all that, that I've recently learned about, which I didn't know. Yeah, those are typically the ones that we work with. Food pantries, it's, again, yesterday we called the food pantries. They're only open on Tuesdays. You know, so, you know, they're very, very limited.
Yeah, so it's hard to do much with that. It's like hit or miss.
Mm-hmm.
And they're screening a lot. There's a program out there for people that have been in nursing homes for an extended period of time, and the goal is to bring them back home. And a few years ago, I had to go to the food pantry. It was quite an experience for me because I had never done that, to set up someone, and it's quite extensive. And like I said, only open certain days, certain times. So transportation, you know, I was lucky that I could go for that person, but they're very limited, and you can only get so much. It's, you know, rice and, you know, canned goods, it's basic stuff. So they'll have milk, though. They did have milk, but then they give you a one-time thing, and then you're done, you know. So in order to go back, there's a lot of paperwork involved, and which is good because you don't want people just going because they need it. ACAP started with they have a little cupboard in front of the ACAP now where people routinely bring in canned goods, and they were saying at the last meeting I was at, somebody will go in and they'll fill it on Monday, Tuesday it's empty. So that's
So
another
there's need.
thing.
We just don't know, what age groups it is.
They don't know. They don't know. So now they're talking about doing that locally in each town, this little food storage thing that they have. We don't know if it's somebody that really needs it or not, but all they do know, when it's full, then the following day it's empty. So either it's going to the elderly population or the younger people. They're kind of not sure who they're serving.
They
at
don't
this
know how
point.
it's being distributed. So
Exactly.
So going back to talking about sort of the different areas, do you find that your referral rates are really different depending on if you're talking about like a more populous area versus like Caribou compared to like the Allagash, or I kind of...
I don't know. I mean, we actually have harder time securing resources, because they can't have delivery in certain areas
Right.
for Meals on Wheels.
Right.
So, in some ways, you would want to refer more in rural areas, but you actually have less access to less resources. So it's kind of, you know what I mean? Whereas really in more populated areas, there's more resources for people because they can have Meals on Wheels delivered home. there's senior citizen centers in these key areas that actually serve a meal.
Hot meals, yeah.
Hot meals.
Yeah.
And so when we're here, we actually probably have more resources for people that live in, so we tend to, we could use it, but they're just not available in rural areas as much. And they rely on the frozen meals. They have to typically go pick those up
Yes.
at a community center, which is usually half an hour
Yeah.
away. Usually pick up 2 meals of, 2 weeks, I think, at a time is what
Right.
they'll release.
Yep.
But what about it would be hard to know because you're going to be talking like much smaller numbers in more rural areas, but do you think there might be a bigger call for these people to be getting home health because of the way they live?
In rural areas, you mean, rural settings?
Yeah, compared to, everything's rural up here really, but.
But there are areas that are, there's less population.
For example, the Allagash, I find that they have more of a family.
Yeah, I would agree with that.
Yeah, especially up in the
They're very
Allagash.
close-knit.
Very
They don't-
close-knit up there,
They
so.
don't, neighbors help neighbors, and they
Yes.
all take care of themselves. I think that's probably
Even around here too,
how
though,
they've
neighbors.
overcome.
Like Van Buren yesterday, my client, the neighbors brings her meals. I wasn't saying, I got last time, neighbors would each take turns bringing her meals. She was dying of cancer. So the neighbors, again, it's our community. I think it's not like that everywhere, but neighbors sometimes play a big role in helping them out, especially with the meals.
Okay. So.
I think, part of me says, and this was said earlier, but I think part of what happens is, in those very rural areas like Allagash, I remember when they were cut off from the flood,
Mhm.
they learned to be self-sufficient, and that culture sustains them.
Mhm.
And so we might not get as much referrals, or we might not have as, like I can tell you, we don't have nearly as many clients in those regions as elsewhere. But I question if it's a consequence of, it's not because of lack of need. I
Right.
think it's because they just adapted and they've learned to create that self-sustaining culture, and they just kind of work with what they have.
Yeah, and that's, I think a lot of people, myself at least, and other members of my group, I think we kind of want to explore that, but it's like, it's kind of difficult because you're talking about a group that the only way you would know what's going on is to go visit them, because you talk to a doctor and says, well, I don't really get any more referrals from them than anywhere else, but
Right.
that doesn't mean they have a less of a need.
Right.
It just means they're not coming to you because it's 40 miles away and they're old and sick. And
Well, they don't go to the doctor really.
No.
They might go once a year. They don't get out. And patients that never see, we're lucky if we see the doctor once a year. Not a lot of people make house calls, so some people end up, going a long time without being able to see anybody.
So you kind of touched on it a little bit when you said that nutritional assessments are part of the nursing
Yeah, it's
visit.
part of the standard visit, yeah.
Yeah.
And Gould assess well, it's not Gould anymore, but when they do the standardized assessment tool to determine eligibility for home health, there's a section on there that looks at nutritional status, asks height and weight, calculated BMI, asks about unintended weight loss or weight gain. Another big important piece for older adults is dentition, assessing their dental needs. As they age, dentures become ill-fitting, they create sores, they have chewing difficulties, swallowing, that type of thing all can play a role in nutritional status.
Yeah.
If they're latter stages of chronic disease, COPD, CHFers, they tend to lose weight, they just have no appetite. When they take 20 pills, they have no appetite, right? That's their breakfast. Takes them. So there's a lot of factors that influence nutritional status. I think that, you definitely see a decline in appetite in an older adult to begin with. They tend to not want to eat a lot. We see our most of the time at supper, they don't really eat a lot. They might have a toast, a bowl of cereal, a little bit of oatmeal. They're not big eaters at night. They're bigger meals at lunch, typically.
So I came across a study that looked at BMI, and actually it kind of didn't really have any conclusions to draw from that. But do any of the referring providers or even the agency itself, is that often a goal in treating these people, is to work on their weight?
So on the long-term care side, we don't necessarily, I think Gould does, I don't know a lot of physicians' offices that are calculating BMI on the older adults, although I think it's part of standardized visit from like federally qualified health centers. But on the skilled side, the Medicare certified side, or other side, there's a lot more emphasis now, and they keep pushing for us to get height and weight. We do a nutritional assessment that's more encompassing now. Medicare is requiring that as part of the, part of the process. And there is a nutritional status, and we do definitely work on nutrition, more so on the skilled side than on the long-term care side.
In that same study I looked at, and it kind of looked, what it found was that if you had a certain score on one of the nutritional tests, I forget which one it was, there was a consequent increase in morbidity and mortality as you got lower and lower on the score. So is there any talk, kind of more like the executive level of that, things like that playing into funding or the way that they're going to decide how to, who gets home health?
Not so much from a nutritional perspective, because nutrition alone, unfortunately, if they have a nutritional deficit, that's not going to qualify them from skilled home health Medicare. That would in isolation. There's a lot more emphasis right now, regionally and nationally, on readmission rates and rehospitalization of patients with chronic conditions, looking at the aging population. So there is work being done. You might want to talk to Area Agency on Aging, or Cheryl Daigle could help you at Northern Maine Medical Center. They've been working with a project where they actually offer all discharged patients, I think that focusing on the above 65, all patients discharged from the hospital, they'll give them 2 weeks worth of frozen meals to take home, because they believe that when patients go home from the hospital, they're deconditioned, they're weak, they might not have all the resources at home, and that was a significant contributing factor to their rehospitalization. I know they gather data. I know that, when I was working with them, I encouraged them to collect specific standardized data. So anecdotally, they're saying that they found that has decreased readmission for them. They've had less hospital readmissions, and they're correlating it to the fact that they're giving them nutrition to take home for 2 weeks. So I think that would be an interesting piece that you could certainly look at too, in terms of that.
Yeah, one of the studies I did, I'd have to look at it again. I don't remember exactly what the data found, but it had to do with hospital stays and weight loss during them, and that increasing the chance of readmission, or throwing them into that upper quartile of being like the 21-day admissions and stuff like that. So
well, Northern Maine's been doing that for some time. I'd say probably for the last year, working collaboratively with Meals on Wheels program to do that and offer the 14 days of meals. And then what happens after that is they follow through with them and offer them, if they're eligible, to stay on, to be able to apply to be on the Meals on Wheels program. They found that successful. I just don't know exactly how they're collecting their data for pre and post comparison. So, but you might want to speak, like I said, Cheryl could tell you a little bit more about that piece. I mean, that certainly would be noteworthy in terms of what the role nutrition plays. And that might be a good group. I don't know how quickly, if you're looking at an aggregate, it would be very interesting maybe to talk to them about the value of that. If you could get names of people that participated and took advantage of that program, you could meet with them, and that might give you some interesting information.
That's good. I think I pretty much touched on the general points that I wanted to go over. Is there anything else you can think of and that you've run across that relates to the topic that you might want to share?
It's too bad they don't have more funding for nutritional, because I firmly believe that if the clients would have better nutrition, half of their probably ailments would go away. When I eat bad for 3 days, I feel terrible. So, it's all in the foods. It's just too bad that there's no money out there to educate them, and even just putting something in a shake with, I'm a big protein drinker, but you know what I mean, they don't know how to do it, and I don't know.
Yeah, I think we lose sight of the fact that we assume older adults in general know how to eat and know how to eat well. They don't. So part of the challenge is that we as a society, case in point, Tyler's saying they don't have any nutritional deficits. How does he assess that? How does he know? Does he ever talk to them about what is your diet like, and looking at the diet and talking about how to educate them on eating right? There's still a fair proportion that don't eat right.
No, a lot. My
Or
God,
diabetics.
790, yeah. Yeah,
I mean, so when I look at that, I think it's a gap in practice, and so some people are almost oblivious to the fact, there's an assumption. It's the same assumption we make when the person, I always say that in class, right? They smoked for 40 years, you assume that they've been asked several times, do you want to quit smoking? But, you know,
Yep.
we can't stop asking and looking, but I don't think there's any, if you look around, there's not really any program out there that works to educate older adults on food.
no.
Unless they develop diabetes, they're gonna be pushed to a diabetes education class, you know what I mean? But other than that, the use of dietitians, I think, is limited.
They have a program in the area, but it was mostly for the younger people. It's funding, but it's to show families how to cook and educate them and all
Was
that.
that through ACAP, their SNAP?
Yes, their SNAP program.
Yeah, SNAP.
Too bad they don't have that for the elderly. They could go into their homes and educate them, you know what I mean? So, but they gave a whole presentation. They have a meeting every month. It's called the Arista Collaborative Meeting, and everybody from the community, from different agencies, go there and they share updates and all that. And should have gone there 20 years ago. You know, there's a lot of resources, and that's where I saw the SNAP. But unfortunately, it's not for the elderly. But there is such a thing to educate people on that. So, yeah, they do cooking classes. They bring in the kids. They show them, you know. So.
Yeah, I don't see any programs like that
No.
for older adults.
No.
Interesting.
All right.
What else you could talk to? Yeah, I don't think there's a lot of, you know.
Yeah, the hospital would be a good place.
And I laugh. I think when I go to the doctor myself, I'm thinking about these older adults and go, no one really ever asks me what I eat. Do they really evaluate your diet? So,
No.
I just think that's interesting.
All right. Well, that was pretty good information. It was more in line with what I expected.
What does
Tyler,
he do,
didn't-
Tyler?
Tyler's a nurse practitioner.
Oh.
He didn't exactly say that there isn't a existing